cortisol has got multiple effects in different regions. It suppresses AVP, and that is why cortisol deficiency will mask diabetes insipidus. And once you start hydrocortisol, you will basically have a stimulation which will happen in that perspective, and that becomes important. It will also have a suppressive effect on TSH. So cortisol deficiency can cause a subclinical hypothyroidism-like picture in which the FT4 is normal and TSH is slightly elevated. So this is not really hypothyroidism. Be a bit cautious before you start treatment. We have seen in a few cases where TSH is 10, 12, 13, something like that. And of course, cortisol will have a suppressing effect on growth hormone. So in MPHD, if you're giving growth hormone, what should be the dose of hydrocortisone? You want to keep it on the lower side or the higher side?
The growth hormone, it is like 8 to 10 milligram per minute.
So you want to keep it the lower, because anyway, the central causes need less amount of hydrocortisone. If you give more steroids, it will counter the effect of growth hormone. As I said, growth hormone and cortisol are opposite. So if you have giving growth hormone and give high cortisol, your effect will be blunted. That becomes important from that perspective, and that is important. Now we have talked about the effect of cortisol on other axes. We'll now talk about the effect of other scenarios in terms of the cortisol axis, and one, of course, is nutrition. So what do you think happens with nutrition in terms of both undernutrition and overnutrition? So obesity, let's say first.
So obesity is a fixed state, so cortisol levels will be low.
Okay.
And the nutrition, it is a stress state, so requirement of cortisol.
So yes, the second point is fine. With malnutrition, your cortisol levels will be on the higher side. But if you think of obesity, don't say that obesity is not a stress state. You always have a right balance of BMI. If your BMI is low, you are worse. But if your BMI is high also, you are worse. And we all know that obesity is a well-known inflammatory state. If you look at CRP levels in obesity, they are high. So obesity also causes hypercortisolism. So that is important to remember. Now, basically, if you look at the nutrition impact, we've got the renin axis, and which is controlling the aldosterone. The major control, of course, is at the level of ACTH, which is regulating. So what does leptin do? Leptin basically has an effect which is directly there at the CRH, and this may have a stimulatory effect as well. There is also an expression of 11 beta HSD in the adipocyte, which will convert into cortisol. So your cortisol levels will be high. What other steroid converting enzymes are there in the adipocyte? Yes, so you will have more estrogen. Then, so you will have more testosterone will be produced from that perspective. So more testosterone, more cortisol, more estrogen, everything will be there, which is going to be produced from that regards. So now if we come back to the obesity, what happens to the HPA axis is your adipocyte is more, 11 beta HSD1 will be more, your cortisol level will be more in that scenario. Leptin will be more, your CRH will be more. So leptin, remember, increases which other hypothalamic hormone?
So leptin increases the stress. Leptin increases leptin and button domination.
Yes. So leptin stimulates GnRH. Leptin stimulates CRH. Leptin stimulates TRH. So it is a very, very important. So what does leptin tell? What does leptin mean?
Like the chronic regulatory state of adiposity means like we.
No, what does high leptin mean to an individual? कि आपका leptin high है. What do you mean by that?
That means we have enough energy.
That means you have got a good bank balance. Now you can go for a vacation, you can do something, you can buy some television or whatever. So if your leptin is high, you will grow. That is one. Thyroid also can go up. So metabolism can go up. That is one mechanism that is trying to get down on the energy. You can have reproduction, you can have fertility, so GnRH will go up. Now, because of the leptin, there is also stimulation of CRH. This is more like a inflammatory response because body wants to counter that. So they are doing all this to improve that. So leptin really controls multiple hypothalamic hormones, and leptin deficiency will cause delayed puberty, hypothyroidism, and also cortisol levels will be on the lower side. That is important to remember. So this is something on obesity. So now obesity, we now know the cortisol levels are high. Now, what does it mean in terms of practical terms? Obesity, cortisol is high. If you do a morning cortisol, what will happen? Suppose somebody says, I want to rule out Cushing's. You do a morning cortisol, levels will be high. So this is what is known as pseudo Cushing's. And when we say pseudo Cushing's, it is obesity, depression, diabetes, all these things can cause pseudo Cushing's. So in obesity, you have to be cautious. And I discussed earlier also, in obesity, you should be cautious of diagnosing hypothyroidism, cautious of diagnosing growth hormone deficiency, and now Cushing syndrome. So in obesity, you have to be very careful. You do a ONDST, LDDST before you make a diagnosis, because otherwise a lot of people will be labeled with Cushing syndrome in that regard. So high cortisol is a scenario which is there. The other impact, of course, is that you have got insulin resistance. Now, what does insulin resistance do in that scenario, Vibha?
So insulin resistance will decrease IGF-1, it will increase IGF,
So free IGF-1 level will be more.
and will
So it will have an impact on the growth hormone, but we are talking mainly in terms of HPA axis. So obesity also triggers this insulin resistance, and this is an important stimulus of the production of adrenal androgens. Now remember, when we say SGA girls have a higher chance of developing precocious puberty, why? Insulin resistance. So puberty is is regulated via the insulin resistance. So if you have obese boys, you will have puberty, but you will not have gonadarchy. So you will have small testes and pubic hair development. So this is not precocious puberty. They will come to you at around 10, 12, 13, 14 years also. They will be obese. And they will have, because the LH-FSH levels are suppressed, your estrogen levels are high. That's why all that is low, but you will have puberty. So that is an important thing to ponder from that perspective. So what we are seeing here is that because of obesity, we have got high level of cortisol. You have got high level of adrenarche, which is also going to happen. Now, I have discussed that adipocytes have got aromatase, 11 beta HSD1, which is also there. They have got production of 17 beta HSD causing androgen productions, but they also produce more angiotensin 2. So what does it mean? This angiotensin 2 will cause hypertension. So that's why obesity, and we all know, and there are many other reasons why obesity causes hypertension, but obesity is one of the most important determinants of hypertension in children. If you look at our own school data, we see as you go from normal weight to overweight, the percentage of obesity is 2-3 times more. When you go from overweight to obesity, another 2 times. So obesity is a very, very important mediator of hypertension, and that may be partially mediated via this increased effect of angiotensin 2 on the aldosterone. So obesity causes increased activity of all glomerulosa, fasciculata, reticularis. You will have hypertension, you will have Cushing syndrome-like picture, and you will have a adrenarche. Now, while we are saying that this subclinical Cushing's, quote unquote, that we are saying is there, it should not be confused with Cushing syndrome. It may actually be doing harm. So when we talk about subclinical hypothyroidism, subclinical Cushing's, subclinical GHD, they will all have a bad effect on bones. So whether you treat it or not is different. There will be a compounding effect of these things on bone and on other effects as well, which will happen as we discussed for NAFLD. So we have already shown that subclinical hypothyroidism is an independent risk factor for NAFLD in obesity. So whether subclinical Cushing's also causes that is something which needs to be evaluated further. Now, what happens with illness to adrenal axis? I think everybody knows that. So Dhwani, what do you think? What is the mechanism and what happens?
interleukins are high, so they will stimulate CRP.
So you of course have got the stress. So you've got the infection, so that ACTH levels will go up. Your cortisol level will go up. And this cortisol is important for what?
like it will also increase the catecholamine.
So it will be important for actually allowing your blood pressure to be maintained. So you know what are the indications of glucocorticoids in shock, septic shock? Yes. So if you do not have cortisols, they potentiate the production as well as the action of catecholamines. So if somebody has cortisol deficiency, in that scenario, just giving catecholamines will not help. You have to give them hydrocortisone also. So that is the reason that it's working. It potentiates their effect as well. So Dr. Vibha, 12-year-old obesity, height is 160, weight is 70, cortisol is 700, ACTH is 30. Do you think we should do an MRI?
Basically, first we have to do that, but then super pushing or behavior.
So we should do a HDDST. So what should be done? Yes. So I think the most important thing, and we'll have a full session on diagnostics of Cushing's, is the biggest problem in Cushing's evaluation is that we are not doing the right test at the right time. Remember, you have to first screen, then diagnose, then classify. So screening, this cortisol is of no value. Single high cortisol is useless. Why do I do cortisol in Cushing's then? Exogenous. So if it is low, that is significant. High value, I'm not bothered. You may have a peak which is picked up. So screening is overnight dexamethasone suppression test, urinary free cortisol, or salivary cortisol. So either one of the three or midnight cortisol. Then confirmatory test is low dose dexamethasone suppression test or a higher cutoff of a urinary free cortisol. Suppose urinary free cortisol normal is 200, your value is 3 times above normal, more than 600, you don't need to do any confirmatory test. Now, once you have confirmed, you then classify. So what is the classification test? ACTH first. So ACTH low versus high. And then if your ACTH is high, you do an MRI. If MRI is normal, then you are in a doubt ectopic, you can do a HDDST. So remember, you have got a screening test is ONDST. Your confirmatory test is low dose dexamethasone suppression test, and HDDST should be done only when you are thinking of classification. Otherwise, your diagnosis will be confused. So this is a classical case of pseudo Cushing's. Now, somebody did an MRI. MRI showed a pituitary adenoma. So this may be an incidental lesion. So before, it may actually be functional also, but you cannot say at the moment. So you should do other tests before you go ahead. Otherwise, people will say, go for surgery. Remember, the prevalence of Cushing's in obese children will be very, very low. What will be the pointer that this obese child may have Cushing syndrome?
If they are short stature.
Yes. So short stature. What else? So what are specific signs of Cushing syndrome in children?
Proximal myopathy, short stature,
Yes.
then we can
Thick violaceous stria, facial plethora. These are the characteristic signs. Just having a buffalo hump, round faces, these are not going to make any difference. So short and plump. This child is not really short and plump. So you can't really label them as Cushing's in that scenario. So this is more of a incidental lesion. We should have done an ONDST and it would have been found to be normal. So careful evaluation before you go ahead with surgery and other plans becomes important. So we have talked about overnutrition. Now, what about undernutrition? And now here, already Dhwani has talked about that there are effects of stress. Malnutrition is a stress state. So you will have greater production of IL-1, IL-6, which will cause increased CRH level, increased ACTH level, and you will have a high level of cortisol. Now, would you confuse undernutrition with Cushing syndrome? Nobody will. So here the pretest probability. So here there's not a diagnostic confusion. So your cortisol is high, people will not think because Cushing's will not be associated with undernutrition. Now, can you have a scenario in which your cortisol levels are high, but the patient looks sick, looks like cortisol deficiency? And they have hypertension, hypokalemic alkalosis, and there is virilization. So patient comes to you with weakness, lethargy, pigmentation. You think this could be Addison's. Cortisol level is 700, 800. You measure BP, it's actually high. There is hypokalemia and there is some clitoromegaly. Resistance state. So if you have glucocorticoid resistance, your levels are high, but it's not acting. So you got these Addison's like feature. Then because of that, your ACTH goes up. That high ACTH will work on the DHEAS to cause all this hyperandrogenism. You will have some effect on the aldosterone, but because of your cortisol levels being high also, your 11 beta HSD will be overwhelmed. So that will cause hypertension in alkalosis. So this is a very rare but interesting scenario which is there. So in undernutrition, you will have a high ACTH and high cortisol level, but your CBG level will also be low. So you will underestimate this cortisol excess which is there. Now, what will be a common endocrine condition of malnutrition or that has multiple endocrine effects? So like, of course, we're talking about malnutrition, but which condition you might see as older individuals with malnutrition? The most severe form is? Yes. So what is the hormonal profile in anorexia nervosa? Yes.
Low IGF-1, high GH, and there will be low.
So leptin is low. TRH will be low. You will have features of central hypothyroidism. You will have low GnRH. So you will have hypogonadotropic hypogonadism, which is the classical picture. You will have high level of cortisol. So this is important. High cortisol with low central hypothyroidism with features of hypogonadotropic hypogonadism. You should think, okay, this is MPHD, but no. First thing, why is the cortisol high? If your cortisol is high, it means it's because of the stress, and this is anorexia nervosa. Now, what will that cortisol do to TSH?
This cortisol.
So that will be a sort of a amplifying mechanism which is there. So you have to be cautious before you label anybody. So anorexia nervosa, the classical presentation is central hypothyroidism, hypogonadotropic hypogonadism, quote unquote GHD, along with a high level of cortisol. That is the picture which will be there in that regards. Now, because your DHEAS is delayed, your bone age is delayed, you will have a delayed adrenarche in systemic illness. So 17-year-old girl with secondary amenorrhea. Now we come to the case, Dr. Manoj. Menarche at 13 years, regular periods, height is 162, weight is only 34 kgs. Now the LH FSH is very, very low. And cortisol is high, TSH is low. So this is?
It is, as we discussed, it is anorexia nervosa and the
yes. So, and it is not a case of cortisol excess. We had that very good talk by Dr. Ved, who talked about this hypothalamic amenorrhea in our program last year about these issues as well, that how cortisol will have an impact on that. So this is classically anorexia nervosa. You can all go and have a look at our website, our courses which are available, and the mobile application. So